So good evening, dear students. Today we are going to start, tonight we are going to do the second free session on this single best answer program for the upcoming exam, ERPM exam to be held in 2023, in April. We posted these SBA questions, single best answer questions, which are very exam-oriented questions. And now, like I can see the poll in the first question itself. So first question itself, I can see students have answered all 5. So that's interesting. So which seems to be a little bit difficult question. That's why. So students have answered like question A, B, C, D, E. All 5 answers students have answered. So still, I think most of about 50%. 50% of students have answered the correct one, but many have answered many have given answers to the other ones as well. But majority of students have got the correct one. So guys, I want you to participate in this one. That's why we made this question and the quiz program to make it very interactive. So I want all of you to participate in this question program. So and that will give you feedback as well. Right. So let's start the questions without further delay. Okay, done. Okay, so let's start the questions. We'll start with the single best answer paper. Question number 1. Question number 1. So we'll do the same thing like as we did before. We'll screen the answers. So DC shock, IV digoxin, IV verapamil, IV adenosine, and IV thrombolytic therapy. So all cardiac emergencies, right? So 30 years old lady presented with chest tightness for 2 hours. So a young lady, a young patient has got chest tightness for just 2 hours duration, just 2 hours duration of chest tightness. And the heart rate, you can see the most important physical sign is the heart rate is so high, 130. So underline that in red. Heart rate is 130. And the blood pressure is normal, 140/80. So patient is hemodynamically stable. The heart sounds are normal and there are no murmurs. Lungs were clear. So lung auscultation is unremarkable. There's no features of heart failure. Saturation is 98%. That's quite good. And next important point that you need to underline in the theme of the question. ECG shows QRS, narrow QRS complexes with absent P waves, and the heart rate is 128 per minute and is regular. So that is the theme of this question. Underline that in red. So what should you underline in red? ECG narrow complexes. So ECG shows narrow QRS complexes with absence of P waves and with a regular heart rate of 128. What is the best management step? So guys, what is the question here we are talking about? So guys, last class also I talked to you regarding this. So that is why when we do one single best answer question, we cover most of other single best answer questions as well. So last class, I taught you about arrhythmias. I taught you what is called broad complex tachycardias. I taught you what is called narrow complex tachycardias. And also I taught you, if you can remember nicely, if you can remember what I taught in the last class, yeah. Yeah. So the narrow complex tachycardias, there are two types. One is regular narrow complex tachycardia, and the other one is irregular narrow complex tachycardia, right? Regular narrow complex tachycardia and also irregular narrow complex tachycardia. So if you can remember, last class I clearly taught you the narrow complex tachycardias. So when you take the narrow complex, where you get ECG complex like this. So if it is irregular, I told you, irregular one is atrial fibrillation with absence of P waves, and the regular one is, yes, what is it? SVT, supraventricular tachycardia. So remember, when you take narrow complex, these are narrow QRS complexes. Broad QRS complexes are like this. These are broad QRS complexes, the top one, and the bottom one is narrow QRS complexes. So when you take narrow QRS complex tachycardia, the P waves are hiding or the P waves are absent. And if it occurs, if the RR intervals are regular, that is, if it is regular, it is SVT or supraventricular tachycardia. And if the RR complexes are irregular, we call it atrial fibrillation. So here in our question is narrow complex QRS complexes with absence of P waves, but is a regular heart rate, regular fast rate of 128 per minute. So it is SVT, supraventricular tachycardia. So once we make the diagnosis of SVT, when they ask about management, the next thing that we have to see is whether it's hemodynamically stable or hemodynamically unstable. I taught you in the last class. So see, when we do our single best answer questions, guys, we are not just covering one question. From the last class knowledge, you can do this question very easily. And we can see the results because most of the students have got the correct answer. So, if the patient is hemodynamically stable, that is where your systolic blood pressure is more than 90, and if the lungs are clear, that means there's no evidence of heart failure. So, systolic blood pressure more than 90, and no evidence of heart failure. That means hemodynamically stable. And that type of patients you treat with, you treat as hemodynamically stable SVT. The hemodynamically stable SVT, how do we treat? If the patient is hemodynamically stable, we first try vagal maneuvers, like you give carotid massage, vagal maneuvers like carotid massage, and see whether the patient is responding. But most of the time, you will have to go for the most specific treatment or the best treatment for SVT. And what is that? IV adenosine. Some students have selected the answer IV verapamil. Verapamil is not the answer because verapamil is the second line treatment. So if you take a patient with hemodynamically stable SVT, there are three treatment modalities for hemodynamically stable SVT. What are they? Number one is carotid massage. But the most important treatment is not that one. The most important treatment or the treatment of choice is IV adenosine. IV adenosine 6 milligrams. And if IV adenosine 6 milligram fails, then you can give another bolus of IV adenosine 12 milligrams. And if that also fails, you can repeat another 12 milligrams. And if that also fails, you have to look for other options. You also have the another second line drug called IV verapamil. IV verapamil, right? And if all these measures fail, you go for the DC shock. On the other hand, if the patient is hemodynamically unstable, that means if the patient's blood pressure is below 90, systolic blood pressure below 90, and if the patient has got features of heart failure, then you straight away go for DC shock. So last class, we had a question where we had to use the answer DC shock. Okay, so here the best answer is IV adenosine. So these are not difficult. Like, I mean, once you know the stuff, they become very easy questions. Answer is D. Question number 2. Depression, hypothyroidism, normal pressure hydrocephalus, obstructive sleep apnea, acromegaly. 55 years old male presented with headache and drowsiness. So middle-aged man coming with headache and also drowsiness, underlying drowsiness. His wife claims that he snores and sometimes chokes during the sleep. So he's having loud snoring and also he chokes during sleep. So what are the key points in this question? Drowsiness, snoring. He's more forgetful in the recent past. He also, so young man, he has become more forgetful. There's some degree of short-term memory impairment. His BMI is 35. What is the probable diagnosis? So let's work out. So I have taught you how to do the single best transformation. This is the single best answer tricks of SBMA DC program. So this patient is BMI is 35. Right? Patient's BMI is 35. If your BMI is more than 30, what do you call that? Obesity. So patient has got obesity, drowsiness. So obesity, drowse, and he's more snoring, and also he's more forgetful. You can call it dementia. Actually, you can't really use the word dementia. Dementia is forgetfulness or memory impairment. Reduced memory. So when a patient has complained of obesity, and also particularly when they are more drowsy, if a patient complains, I am feeling more drowsy, fatigued. What is the first and foremost investigation you will do? Dear students, these are very important things. When you start practicing as a doctor, when people complain of increased drowsiness, it's a very common complaint. And also fatigue, you must do 2 tests, or actually I would say 4 tests. Like, first of all, if a patient complains of drowsiness, they are more drowsy than before. They are more drowsy than before. And also they are fatigued than before. What are the tests you are going to do? One is you go to check the hemoglobin. Why is that? So write down these things. Number one, hemoglobin, full blood count. Why? When the patient is anemic, anemia can cause all these symptoms: drowsiness, fatigue. Yeah. Then TSH, to see whether the patient is hypothyroid. Because they are very drowsy and also they are more forgetful and they are fatigued. Number three, diabetes. So when their blood sugar goes up, that also causes them to feel very fatigued and also drowsy. Number four, hyperlipidemia, high cholesterol. High cholesterol also can cause increased drowsiness and also fatigue. So if a patient complains of drowsiness, you must always do these 4 tests, right? So here, more than other conditions, the most likely thing is because patient has got loud snoring during sleep, and also he chokes during sleep with obesity. So those things, and also increased forgetfulness, because diabetes, hyperlipidemia, or anemia, they will not cause forgetfulness, and that is beautifully fitting with the diagnosis of hypothyroidism. So what is the investigation you got to do? A TSH. Why? You are suspecting hypothyroidism. So for hypothyroidism, the first line screening test is TSH, not free T4. It is TSH. Remember that, dear students. So the screening test is not free T4. It is TSH. So answer is B, hypothyroidism, and the screening test is TSH. Right. Question number 3. Pulmonary metastasis, brainstem metastasis, pulmonary embolism, morphine overdose, amitriptyline overdose. 25-year-old woman was diagnosed leukemia and on palliative treatment. So a patient, very young patient, 25-year-old patient, was diagnosed of a in-stage cancer, leukemia, and patient is having a very bad cancer, because the thing is, that's why now leukemia, acute leukemias, usually we start treating them. Acute myeloid leukemia, acute lymphoblastic leukemia, we do give curative treatment, but particularly for a younger patient. But now the doctors have decided on now the doctors have decided on palliative treatment. That means patient is having a sort of a end-stage carcinoma. One student has asked the screening test for hyperthyroidism. So screening test for hyperthyroidism, you got to do free T4 and TSH. That's for hyperthyroidism. Hyperthyrotoxicosis, you will do free T4 and TSH both together. But for hypothyroidism, it's just TSH alone. And students have asked for obstructive sleep apnea. Obstructive sleep apnea, yes, you can get loud snoring. You can have obesity, but obstructive sleep apnea is not a final diagnosis. You must always look for a cause of obstructive sleep apnea. This patient has, so you are right. So the patient has got obstructive sleep apnea, but that is due to hypothyroidism. That is due to hypothyroidism. So yeah, because so I'm just rethinking of your answers. So like, yeah, hypothyroidism is the most likely answer, but as you all said, obstructive sleep apnea is also correct, like it's so equally correct. But what I'm saying is, always obstructive sleep apnea, you must look for the underlying cause. So obstructive sleep apnea also correct here, because the thing is, patient is having obesity, and also patient has got loud snoring, and sometimes chokes during the sleep, and headache, drowsiness. Yeah, even I would take D as a correct answer. Yes, I will give correct marks for that as well. Yes, you are right. Good. So hypothyroidism is correct here. B is correct, and also D. So B and D both are correct answers. Sometimes there are questions, very rarely, there are questions where two answers can be correct. So good argument. I like that. Very good students. So B and D both are given correct answers. Very good thinking. Good on you. Right. So now this patient with leukemia, patient is on palliative treatment, was brought to A&E in coma state. Right? She was drowsy with a Glasgow coma scale of 10 out of 15. So patient was very drowsy and in coma state. Pupils are 1 millimeter bilateral. So that is the theme of this question. So patient is presenting in coma state with pinpoint pupils, bilaterally pinpoint pupils, not unilateral, but bilateral pinpoint pupils. They were 1 millimeter bilaterally. Respiratory rate 8. So respiratory rate is also low and the saturation is also low, 80%. However, lung examination is normal. So if you think of a patient where saturation is low, so patient should have either pneumonia or patient should have something like bronchiectasis or patient should have something like asthma or COPD or fibrosis or something should be there. And in those situations, the lung auscultation, obviously you will hear either crepitations or wheezes or something like that. But are there situations where lung examination is normal, but due to other related structures of lungs, where you can have low saturation? Yes. One is pulmonary embolism. In pulmonary embolism also, your lung auscultation is normal, but the saturation is low. That is because problem with the pulmonary circulation, pulmonary artery. And the other situation is where the nerves, the respiratory center, when the respiratory center is affected, your lung auscultation will be normal, but you're not breathing. You're not breathing because the respiratory center is affected. So that is why the respiratory rate is also reduced. So patient is in coma state with a reduced respiratory rate and therefore the saturation is low. However, lung auscultation is unremarkable. What is the likely diagnosis? A slightly difficult question. So here, the key point is young patient with a cancer and patient is on palliative treatment. Palliative cancer treatment. So what are the drugs that we use in palliative cancer treatment? We give morphine, we give sometimes pethidine, we give tramadol, that type of drugs we commonly use, the pain relief medications, like opiates. We use morphine, we use methadone, we use tramadol, drugs like that. So patient is on palliative cancer treatment and patient has got reduced respiratory rate with low saturation. And the lungs are normal. And the most important physical sign, the theme of this question, bilateral pinpoint pupils. Even in the last class, we had a question on bilateral pinpoint pupils. So there are only 3 conditions where you get bilateral pinpoint pupils. So see, when you put boxes like this, it becomes very easy for you to work out the answer. So, like at least in your training period, where you train yourself for the single best answer question, you must write these boxes besides the question. And write these boxes and then try to work out your answer and you try to learn or you try to study based around the question. Don't just keep reading the book and then go and study, do the questions. It's no point. Always, my teaching is do the questions and read around the question. And when you do so many questions, you have got lots of knowledge in most of the important areas in medicine. Because rather than reading all unwanted areas, you should read most questioned areas in medicine. So look at this. So what are the 3 causes of bilateral pinpoint pupils? One is organophosphate poisoning. The other one is opiate poisoning. That is morphine or pethidine or methadone poisoning. That is opiate poisoning. And the other one is pinpoint the pontine hemorrhage, right? Brainstem hemorrhage. So here, patient is on palliative cancer treatment and reduced respiratory rate with hypoxia, with normal lungs, and patient has got bilateral pinpoint pupils. So this will beautifully help you to diagnose opiate overdose, like morphine overdose. Why? Bilateral pinpoint pupils with reduced respiratory rate, with normal lungs. And also to make it easy, patient is on palliative cancer treatment. So where patient is on lots of pain relief medications like morphine. So this is due to opiate overdose. So patient is on palliative treatment, young patient, they get depressive thoughts, patient would have taken overdoses. So answer is morphine overdose. D. Question number 4. So quickly we screen the answers: furosemide, nitrate, insulin dextrose, hemodialysis, calcium glucose. So as we read the answers, we know the question is on hyperkalemia management. So we are focused. Why? Calcium gluconate, hemodialysis, insulin dextrose, nitrate is of course not going for that, but furosemide or maybe pulmonary edema as well. Let's see something renal. 30 years old man presented with dyspnea and anuria for 1 day after a snake bite. So patient was bitten by a snake and patient is presenting with dyspnea and anuria. So patient has completely absent urine output with dyspnea. Why do you get that? That is because patient has gone into acute kidney injury, acute renal failure. So when a patient goes into acute renal failure, their urine output can be reduced initially, oliguria, and finally they go into anuria. That is where their urine output is completely absent. And when the urine output is completely absent, you get go into a state what we call fluid retention. Why? You're not passing urine. So you're not removing your water from the intravascular compartment. So because you are not removing fluid, water from the intravascular compartment get overloaded with fluid, and that will get collected in lungs, in the peritoneum, and also around the eyes, and also in the ankles as edema. So you do get pulmonary edema, you get ascites, you also can get facial puffiness, and also you get ankle edema. So see, beautifully we are explaining how things are happening. So all due to reduced urine output. And due to pulmonary edema, you do get dyspnea. So patient after a snake bite, maybe Russell's viper bite. Russell's viper bite is notorious to cause acute renal failure, and patient has gone into AKI, acute kidney injury, and that's why patient is having anuria and dyspnea. Sodium is 145, that is normal, and potassium, look at that, that is the theme of the question. Potassium is 6.6, very high. What is the normal range of potassium? Is 3.5 to 5. 3.5 millimoles to 5 millimoles is the normal range of potassium. And when the patient, when the potassium level goes above 5.5, you can get hyperkalemia related problems. Particularly when the potassium level is more than 5.5, you can get hyperkalemia related problems. So what are the hyperkalemia related problems? Write down. You can get acidosis. When you get hyperkalemia, you can get metabolic acidosis. And also hyperkalemia causes damage to the heart muscle. You can get myocardial toxicity, myocardial lesion. So what are the hyperkalemic ECG changes? Number 1, write down. Tall tented T waves. You get tall and tented T waves. You get peaked T waves. Your T waves in the ECG, they become very tall. Like this. You get very tall T waves. Then this P wave becomes absent. P waves disappear. P waves. And this QRS become broader. Broad QRS. QRS become broad. And finally, you get a wave pattern called sine wave pattern. sine wave pattern. So write down fast. So you get tall tender T. Tall tender T wave is the first stage, or hyperacute T. Hyperacute T. So there are different terms. Hyperacute T waves or tall tender T waves. Then absence of P wave and the broadening of the QRS complex, and finally sine wave pattern. So these ECG changes can occur representing myocardial damage by high potassium level. Right? So in this question, you can see, and if you get these changes, what is the first line treatment? You have to give intravenous calcium gluconate. That is a life-saving drug, IV calcium gluconate. Without that, you can't save their lives. Right? IV calcium gluconate is the life-saving drug here. And not only that, you also need to start on a treatment to reduce the potassium level, like you have to start a drug called insulin dextrose solution. So you give calcium gluconate first, and then immediately you start on insulin dextrose solution repeatedly, back to back. Also, you give calcium gluconate, calcium gluconate, I don't, then insulin dextrose. Then you start salbutamol nebulizations to keep the potassium level low. You give potassium binding resins, like calbine or calcium resonium, calbine. They bind potassium in the intestines, potassium binding resins. Then also you can you have to go through the drug chart and see when the patient is on any potassium retaining drugs like spironolactone or ACE inhibitors or angiotensin receptor blockers. So if that is the case, like enalapril, losartan, that type of drugs, you should withhold them. And finally, if nothing worse, then you have to go for hemodialysis. So that is the treatment of hyperkalemia. So see, I have beautifully explained not only the question, but also the treatment of hyperkalemia and hyperkalemia-related changes. So here, patient's potassium is high, 6.6, and the creatinine is also very high, is 4 milligrams per deciliter. But the upper limit of serum creatinine, 1.2. So obviously, patient has gone into acute kidney injury with a very high creatinine level and anuric also. And look at this, underline this in red. ECG tall. So two things you have to underline in red. One thing is potassium 6.6, and the other one is ECG tall T waves and absent P waves. So patient has got myocardial toxicity. And what is the treatment? You have to give IV calcium gluconate. And chest X-ray also showed pulmonary edema. But we are not going to cover the pulmonary edema. First of all, the first treatment is you have to treat the killer first. But the killer is hyperkalemic myocardial injury. And for that, what we give is intravenous calcium gluconate. Answer is E. Question number 5. So quickly we glance through the answers. Guillain-Barré, diabetic peripheral neuropathy, transverse myelitis, sentinel spinal artery thrombosis, subacute combined degeneration of spinal cord. So we quickly went through the answers. Most of them are related to the spinal cord or peripheral neuropathy like Guillain-Barré. Let's see. 60 years old diabetic hypertensive man presented with weakness and numbness of both lower limbs for 5 days duration. So middle-aged man having diabetes and hypertension, coming with weakness and numbness of both lower limbs for 5 days duration. He has got weakness, by both lower limbs are weak, and also there is numbness. And it is acute duration, 5 days duration. So whenever you hear this story, where you have got weakness of lower limbs acutely, what are the things which come to your mind? What are the diagnoses which cross your mind? Yes? One thing is Guillain-Barré, because it is not one-sided weakness. One-sided weakness, what is the first diagnosis which come to your mind? Stroke. If it is unilateral weakness, that means one-sided weakness, or what you call hemiplegia, then the first diagnosis which come to your mind is stroke. But when you talk about bilateral weakness, bilateral lower limb weakness, what are the diagnoses which come to your mind? Either it should be a problem of the nerves connecting both lower limbs, the peripheral nerves connecting both lower limbs, like Guillain-Barré, or it should be a problem with the spinal cord, which gives nerves to the both lower limbs. So that is so if it is Guillain-Barré, it is low motor neuron type by peripheral nerves. Write down these things, very important points I'm giving. So see, I make it so simple for you guys. So always the neurology lessons that we give, I think that was the most favorite among all the senior students our neurology lectures was because so many students suffer from various places where they don't teach neurology properly, but our neurology made it really, really, really easy for everyone to understand. So when a patient has got both lower limb weakness, what are the problems? So this is a spinal cord. It can be due to nerves. So it can be a problem of the peripheral nerves. Right? So write down bilateral lower limb weakness. It is due to a problem of bilateral peripheral nerves. What is the problem? Guillain-Barré, GBS, Guillain-Barré syndrome. That is paralysis of bilateral lower limb nerves, peripheral nerves, Guillain-Barré. So when you get damage to the peripheral nerves, connecting both lower limbs, you can get lower limb weakness, that is low motor neuron type. So I'm going to put LMN here, low motor neuron type. Then it can be a problem with the spinal cord. It can be a problem with the spinal cord. Because spinal cord only gives nerves to the lower limbs. So this is upper motor neuron type. So spinal cord problems. So what are the spinal cord problems? So I'll write a cord. So cord problems are upper motor neuron type, UMN. So what are the spinal cord problems? You can get something called transverse myelitis. The common ones, huh? I'm not giving everything, but common ones. Transverse myelitis. You can get spinal cord compression. So transverse myelitis is acute, right? Guillain-Barré also acute. Spinal cord inflammation is acute, that is transverse myelitis is acute. But spinal cord compression is chronic. So spinal cord compression, it can be either Pott's disease like in TB, Pott's disease, tuberculous compression, or it can be due to malignancy. But those are chronic problems. So number one, transverse myelitis. Number two, spinal cord compression. Number three, it can be due to something like vascular lesion of the spinal cord. So what is the vascular supply to the spinal cord? There's anterior spinal artery, posterior spinal artery. So this anterior spinal artery, they can get thrombosis, or you can get a blood clot in the anterior spinal artery. Because the spinal cord, you have, when you take the cuts, so a little bit difficult part, because you, I don't know whether you have done the neurology, whether you have gone through my lectures. All these are beautifully explained in my neurology lectures. Right, so you have here lateral spinal pelvic, lateral spinal pelvic tracts. These are the posterior columns. And here you have the pyramidal tracts. So when you take the spinal cord cut section, you have, so right now, this is pyramidal tracts, or what you call corticospinal tracts, the motor pathway. Corticospinal tract or the pyramidal pathway. Pyramidal tracts. Then you have lateral, this is lateral spinal pelvic tract. Lateral spinal pelvic tract. What are the nerve fibers carried in that? Pain sensation, pain and temperature. Pain and temperature. So pain and temperature sensations, they are carried in the lateral spinal pelvic tracts. Lateral spinal. Then this is called the posterior column. Posterior column. In the posterior column, what are the sensations carried in there? You have the light touch, 2-point discrimination, vibration sense, and the joint position sense. Joint position sense, or what you call proprioception. Let me repeat that again. So lateral spinal pelvic tracts, they carry pain and temperature sensation. And the posterior columns, they carry joint position sensation, what we call proprioception, then 2-point discrimination and vibration sensation, plus light touch. So this area, the anterior part of the spinal cord, is supplied by anterior spinal artery, and the posterior part is supplied by posterior spinal artery. So when you get anterior spinal artery thrombosis, you get damage to these motor fibers. You get damage to these motor fibers, pyramidal tracts, this upper motor neuron type of paralysis because it's a spinal cord problem. Plus, you get damage to the pain and temperature pathways, lateral spinal pathways, because anterior spinal artery supply area. But your posterior column sensations are intact. Why? That is supplied separately by the posterior spinal artery. Understand? So in that type of situation, your posterior column sensations like vibration sensation, joint position sensation, they are intact. Right. Then what are the other reasons why you get bilateral lower limb weakness? Now see, this is a very important topic. If you take medical students or even sometimes even registrars, about 7 medical students, of course, I would rate it as 99%, or registrars, I would rate it as 60%. Like they don't understand these simple basics behind this bilateral lower limb weakness, but we are teaching this. So the other reason why you get bilateral lower limb weakness is this muscle weakness, proximal muscle weakness, is the muscle. Proximal. The other problem is muscular. So what are the examples? The muscle weakness, proximal myopathies. Proximal myopathies, like when you get conditions like polymyositis, write down, polymyositis. Various other myopathies like Duchenne muscular dystrophy, Baker's muscular dystrophy, things like that. So this second, yeah, can I call you later? Can I call you? Can I? Yeah, sorry. The other reason why you get bilateral lower limb weakness is due to muscular problems. So either peripheral nerves like Guillain-Barré, which is acute, or it could be spinal cord problem, either transverse myelitis, which is acute, spinal cord compression, which is chronic, or anterior spinal artery thrombosis, which is also acute. But the muscular disorders are always chronic. Right. I give you lots of huge area I cover with a lot of neurology theory. But all these covered in my lectures, in those studies of modules. So going back to the question. So yeah. So this 60-year-old diabetic hypertensive man presented with weakness and numbness of both lower limbs for 5 days duration. On examination, reduced pain sensation up to the nipples. So up to the nipple level, the pain sensation is reduced. Now remember, in Guillain-Barré, sensory system is unaffected. Only if you get a spinal cord problem, right? In spinal cord disease, only you get damage to the sensory system. So like when you get transverse myelitis, spinal cord compression, and also when you get anterior spinal artery thrombosis, you get damage to the, or you get problems with pain and temperature sensation, right? Your pain and temperature sensation will be absent. So here, patient has got a sensory level. Up to the nipple level, the sensations are absent. So that itself says it is a spinal cord problem and not Guillain-Barré. Because in Guillain-Barré, sensory system is intact. Joint position sensation intact in both legs. Now that gives the diagnosis. Now here, patient has got a sensory level, therefore it has to be a spinal cord disease. But in a condition like transverse myelitis or spinal cord compression, both lateral spinothalamic tracts as well as posterior columns, both tracts are damaged. Therefore, all the sensation like pain, temperature, joint position sensation, everything is gone. But as I taught you before, anterior spinal artery thrombosis will only cause damage to the lateral spinothalamic tracts, sparing the posterior column sensation. So the joint position sensation is intact. Reflexes were exaggerated in both lower limbs because it's an upper motor neuron lesion. You know, in Guillain-Barré, reflexes are absent. In Guillain-Barré, you get areflexia. Plantar upgoing. Why? It is an upper motor neuron lesion, so you get bilateral upgoing plantar. Upper limbs neurologically normal because it's a spinal cord problem. So therefore, upper limbs are unaffected unless so upper limbs will be affected only if you have got a high spinal cord injury. That is, if you get a lesion above the C4 level, then only your upper limbs will also be affected. High cervical spinal injury, only you will get damage to the upper limbs. Otherwise, anything below the cervical spine level, C5 level, your upper limbs are unaffected. So what is the diagnosis? So now the two close answers, one is transverse myelitis, the other one is anterior spinal artery thrombosis. The answer is because the joint position sensation is intact, it has to be anterior spinal artery thrombosis. Answer is D. This is a previous final MBBS question. Two questions. Question number 6. If we glance through the answers, ORS, that is oral rehydration solution, 100 ml per hour. IV ceftriaxone, stool culture, catheterization and monitor urine output, IV 0.9%, normal saline 500 ml bolus. So it's an acute situation where the fluid resuscitation is being mentioned. Let's see. 25-year-old boy presented with a fainting episode following 6 to 8 episodes of profuse diarrhea. Yes, so it's hypovolemia. So patient has got profuse diarrhea, 6 to 8 episodes of profuse diarrhea, and after that patient presented with fainting. So we read the answers. And so diarrhea, fainting. How can you relate those things together? So diarrhea means you get intravascular volume depletion. That means you lose from the extracellular compartment. There are two compartments, extracellular, intracellular. So extracellular compartment, there are two divisions. What are they? Intravascular and interstitial. So here, patient has lost fluid from the intravascular compartment. That's why patient has fainted because of low blood pressure due to cerebral hypoperfusion. So after consuming takeaway foods, so patient has got tachycardia and the blood pressure is low, 90/70, and the pulse pressure is also low. Pulse pressure is 90 minus 70 is just 20. Saturation is normal, 98%. He was anuric. So see, nice case. Diarrhea, profuse diarrhea, hypotension, and patient fainted, and now anuric. So what does that mean? Low blood pressure, reduced cerebral perfusion causing fainting, plus reduced renal perfusion causing anuria. And what is the diagnosis? Hypovolemic shock. Diagnosis is hypovolemic shock. Write that down. And he was anuric for more than 10 hours. What is the next step in acute management? Yes, what is the next step? If the patient is hypovolemic, you have to give fluid, nothing else. So the treatment of choice is giving normal saline boluses. Normal saline boluses. So very simple. If you know the steps, like if you can understand the question clearly, if you make the diagnosis that it is hypovolemic shock, the best chance is give saline boluses. 0.9% normal saline bolus. Answer is E. If the patient did not go into hypovolemic shock, then what would be your answer? Patient is having only slightly reduced urine output, but patient's blood pressure is normal. Then what is the answer? Then it has to be oral rehydration solution. But here, patient is in shock. So you have to give saline boluses very fast to get the blood pressure up. Question number 7. We'll screen through the answers. Blood transfusion, IV ceftriaxone, IV vitamin K, oral metronidazole, and subcutaneous insulin injection. Answers did not really lead to any clue, but we'll go through the question. 45-year-old male, diabetic, CLCD, so diabetic and also chronic liver cell disease patient, presents with hematuria, hematemesis, I'm sorry. So CLCD patient, the chronic liver cell disease patient with diabetes, presented with hematemesis, there is upper GI bleeding for 2 days duration. Previous upper GI endoscopy reveals esophageal varices and banding was done. Now remember guys, whenever we see, I do this by myself, like when we get patients with cirrhosis, with hematemesis or melena, we do the endoscopy, and once the endoscopy we see there are grade 3, grade 4 varices, we do what is called banding. So we have these banding kits, and through the endoscope itself, we install these bands and we put banding and ligation to those varices, and that there is bleeding from those sites. But once you put bands, it doesn't remain like that forever, because due to portal hypertension, new varices form. So even if you have put bands once, then there can be formation of new varices, and those can burst and you can get bleeding. And that's what happened. That's what has happened to this patient. So it reveals, so previous esophageal varices, and that was banded, but this time again he would have got reappearance of varices, and that has burst, and patient has got hematemesis. There was tachycardia, pulse rate 110, blood pressure is low, 80/50. So patient again has gone into hypovolemic shock. Why? Bleeding. So see guys, all themes are same. The previous question, this one, themes are same. So here, bleeding. How do you know bleeding? Hematemesis. And what is the situation now? Patient has gone into hypovolemic shock with low blood pressure and tachycardia. And patient is also in shock state. To support that argument, they are mentioning that patient has got cold peripheries. Patient is icteric and having flapping tremors and ankle edema, that is due to cirrhosis. Cirrhosis patient has got ankle edema, patient is icteric and has got flapping tremors, that is patient is in hepatic encephalopathy as well. What is the next management option? Guys, very simple. Previous question, what is the theme of this question? Hypovolemic shock. So previous question, the diarrhea causing hypovolemic shock. And now this question, bleeding varices, upper GI bleeding. Upper GI bleeding has caused hypovolemic shock. So earlier, what did we give? IV fluids, 0.9% normal saline boluses. And here, what is the problem? Is bleeding. So if it is bleeding causing hypovolemic shock, what is the best treatment? It is blood transfusion. Of course, until blood is ready, you can give some saline boluses. But what is the best management option? It is blood transfusion. So the answer that we expect in this type of question is blood transfusion, nothing else. It's a famous surgery question as well. So if a patient is in hypovolemic shock due to upper GI bleeding, the treatment of choice is blood transfusion. So answer is A, blood transfusion. Question number 8. Screen through the answers, intubate and ventilate, gastric lavage and activated charcoal, IV atropine boluses, IV atropine infusion, IV saline bolus. So it's a poisoning related question. Atropine bolus and atropine infusion, gastric lavage, intubate, ventilate, saline. Could be organophosphate or carbamate. Let's see. 25-year-old farmer presented with unknown poisoning. We don't know what the poison is. And found to have bilateral bilateral pupils of 1 millimeter. See, again, like the previous question, bilateral pinpoint pupils. Why 1 millimeter? Normal pupil sizes are 2 millimeters. But here, bilateral pinpoint pupils, 1 millimeter. Heart rate is 52. So, what are the key points in this question? One is pinpoint pupils, and also patient has got bradycardia. Patient has got bradycardia. Blood pressure is 90/60. It's also on the low side. And the respiratory rate is 32. See, the previous question, respiratory rate was low. Why? Due to morphine, the respiratory center was suppressed. So, therefore, previous question, respiratory rate was low. But here, patient is having dyspnea because patient has got pulmonary edema as well. So, here, patient has got increased respiratory rate. And the saturation is 94%. He was drowsy. What is the next step in management? So here in this particular question, patient has got pinpoint pupils. So write down these themes, these are SPA themes. Then bradycardia. Increased respiratory rate. And patient is drowsy. What is the poisoning, guys? Pinpoint pupils with bradycardia, that is the theme. Bilateral pinpoint pupils with bradycardia. What is the answer? It's organophosphate or carbamate poisoning. So I will say OP poisoning. OP poisoning. Now, what is the treatment of OP poisoning? So, if the patient has ingested organophosphate within 2 hours, if the ingestion of poison is less than 2 hours duration, and if the patient is fully conscious and not drowsy, you can do gastric lavage. You can do gastric lavage. But here, the duration is not mentioned, and also they say the patient is drowsy. So, drowsy patient, you cannot give gastric lavage. You cannot go for gastric decontamination with activated charcoal because patient is drowsy. So, and what is the best treatment of organophosphate poisoning? It is not gastric lavage or giving activated charcoal that we give if the patient is not drowsy. But the best treatment is you have to counteract the muscarinic features. So, what are the muscarinic features of organophosphate poisoning? So, remember, guys, organophosphate poisoning causes muscarinic features as well as nicotinic features. What are the muscarinic features? You get so the easy mnemonic to remember is mud piles. Mud piles. MUDPILES. MUD, mud. M is meiosis, that means pinpoint pupils. Meiosis. U is urination, increased urination. D is diarrhea. Right? Yeah. Mud piles. You get pupil. Yeah. So you can get meiosis. Then increased lacrimation. Yeah. Mud piles is there. No, actually, more than mud piles is better to remember the other mnemonic. That is the other one. Yeah, mud piles. So let me check. Increase lacrimation, piles, and excessive salivation. Increase lacrimation and excessive salivation. Those are the muscarinic features. In addition to this, you also get bradycardia and hypotension. Bradycardia and hypotension. So just write down the classical features of organophosphate muscarinic features are you get bradycardia, hypotension, so your pulse rate is below 80, and the blood pressure, systolic blood pressure drops below 80, and you get pulmonary edema. Your lungs are full of secretions, pulmonary edema. You get increased lacrimation, increased salivation, you get excessive urination and excessive diarrhea. And also you get diaphoresis, excessive sweating. You get diaphoresis, excessive sweating. So those are the features of muscarinic toxicity. What are the nicotinic features? Nicotinic features are you get muscle twitching, skeletal muscle paralysis, you get neck muscle weakness, and also you get respiratory muscle weakness, patient going to respiratory arrest. So nicotinic features are muscle twitching, skeletal muscle weakness, that is you particularly get neck muscle weakness, and the respiratory muscle weakness causing respiratory arrest. Those are nicotinic features. Right? Okay. So the muscarinic features have developed in this patient, and that is organophosphate poisoning. So how do we treat organophosphate poisoning? We give drugs. That is, what is the drug of choice? This atropine. We give atropine boluses initially to counteract the muscarinic toxicity. And then once you give the boluses, then we continue with atropine infusion. So here in this question, you have to give atropine boluses, first of all, until your heart rate is above 80, your systolic blood pressure is above 80, your lungs are clear, and patient's pupils are no longer pinpoint. And then only you continue with the atropine infusion. Yeah. So here answer is atropine boluses. Answer is atropine bolus. Answer is C. Just give me a second. I have to answer call from the hospital. Just give me 1 minute. Sorry about that, guys, because there was a patient in my ward who was really bad. This Buddhist monk, he has arrested, so I had to give the plan of management this one. Okay, to my juniors. Right. Okay. So the answer was C in the previous question number 8. Question number 9. Ulnar claw hand deformity, wrist drop, weak extension of fingers, weak shoulder abduction, weak shoulder adduction. A neuroanatomy question. So in the recent past, in the ERP papers, we have seen lots of neuroanatomy questions as well. 35-year-old man presented after a road traffic accident and had a fracture of upper humerus. So he had a road traffic accident and had a fracture of upper humerus. Which of the following mostly suggests the relevant nerve injury? Which of the following suggests the relevant nerve injury after an upper humeral fracture? So ulnar claw hand deformity, no. Ulnar claw hand. So what is ulnar claw hand? Like this. This is so when a patient has got C8, write down this C8 T1 root lesion, you get a true claw hand deformity. You get clawing of all the fingers. This is claw hand. That is C8 T1 root lesion. If you get something like this, you can keep the first, second, third fingers extended, but fourth and fifth fingers, they are flexed. This is the ulnar claw hand. And ulnar damage, usually you get at the supracondylar fractures here. The low end of humeral fractures. If you get a low end of humerus fracture, you will, that is what you call supracondylar fracture, then you can get an ulnar nerve damage. And usually when you get upper humeral fractures, here you do the important structure, what is that called? Spiral groove or the radial groove. In the spiral groove, what important nerve troubles in that? It's the radial nerve. And due to damage to the radial nerve, you get wrist drop. So, when people after Saturday night, when they sleep like this, keep in their hand like this, what happens? The nerve get compressed, the spiral groove, and next day morning when they wake up with the hand like this. What is that called? Saturday night palsy. Saturday night palsy. Again, due to neuropraxia, due to compression of the radial nerve. So here again, upper humeral fracture that will cause radial nerve damage, causing wrist drop deformity like this. You cannot extend the wrist. Wrist drop deformity. So answer is B, wrist drop. Last question. Intravenous atropine, gastric lavage, insertion of a temporary pacemaker, observation only, activated charcoal. Again, a poisoning question. You definitely get one question from poisoning, right? And snake bite. That's definitely in ERP paper. There'll be definitely one question from poisoning as well as snake bite. 20 years old, it can be either single best answer or MCQ, but one of them you definitely get a question. 20-year-old woman was admitted 30 hours following ingestion of yellow oleander seeds. So after several hours of almost 1.5 days after ingestion of yellow oleander seeds. So what is the active ingredient in yellow oleander, or what you call kahakanero? It is digitalis glycoside. Digitalis glycoside, like digoxin poisoning. Her pulse rate was, so that causes severe bradycardia and heart blocks. It can cause bradycardia, heart blocks, first degree, second degree, and complete heart block as well. They also can cause ventricular biogenesis. They can cause potassium changes. They can get hypokalemia. That also can occur. And they also get yellow vision, what we call cetopsia. Even seizures can occur. So ECG showed a second degree heart block, and also the heart rate is 48 beats per minute. What is the next step in management? So guys, this patient has got cardiac toxicity and several hours later. So there's no point giving activated charcoal. There's no point giving gastric lavage. Why? It is valid only within the first 2 hours of poisoning. After 2 hours, no point. And patient has already got cardiac damage. So the only hope for this patient is insertion of a pacemaker. And so what you need to do is you have to insert a temporary pacemaker. Answer is C. Answer is C. Let's go through the MCQs quickly. So I think you would have. So I'll just give you just a or 2 minute break before I start the MCQ. Don't go away. I'm going to just start just maybe 1 minute just to have a glass of water. So single best answer question. This is the way we do. We don't waste time by telling. So in my classes, I don't just chat around politics and I don't chat around all the jokes and things because I don't like to waste time. Time is so precious for me, and time is so precious for you also. So like we do it fast because it's all exam oriented, target oriented, because you have a goal, guys. So ERPM exam is going to happen in April, and very short period you got. And during that short period, we have to cover all the topics in internal medicine. Cardiovascular system, respiratory system, neurology is huge, endocrinology. And so we have to go with fast in order to achieve this. But the fast means it's not just telling answers. You can see the neurology question, how many minutes I took for you to explain all that. So I take a question and I give all the theory behind that. So there are enough students, you can also see, there are enough students, those who have not read a single word in medicine, but just practice our single best answer questions and MCQs. There are enough students. I can, I just can't remember the names on top of my head, but there are enough students. You can also see this. They just came for our single best answer course. They just came for our MCQ course, the question-based classes, and just read around it little bit. And even if you don't read, because I teach you all the important stuff there in a class, but I encourage you to read as well, just around that question, just a little bit area. And by doing that itself, you can fact the exam, you can easily pass the exam. That guarantee is given. But you have to read, okay? And you should use your brain, you should learn how we worked out answers. And just, even if you haven't read a single letter in medicine, still by doing the single best answer program and the MCQ program, you can easily secure pass mark in medicine. I give that guarantee. But you should be prepared for that. Okay, right. So take a 1 minute break, and after that we'll start the MCQ. So let's start the MCQs now. Yeah. So the MCQ paper, question number 1. Regarding acute kidney injury. So it's a renal medicine question regarding acute kidney injury, or what you call acute renal failure. NSAIDs is a recognized cause, obviously. So particularly in elderly patients, we always tell that you need to use NSAIDs with caution. Why? They can cause acute tubular necrosis and acute interstitial injury. So they can cause acute tubular necrosis and also acute interstitial kidney injury. Therefore, you have to be very cautious when you are starting NSAIDs in elderly patients. So definitely it's a very well recognized cause. That's true. Cephalosporins is given for associated infections. Remember, pyelonephritis, acute pyelonephritis also can cause acute kidney injury. So when you get acute pyelonephritis, UTI, which is a well-known cause of AKI, acute kidney injury, we do give cephalosporin drug, ceftriaxone. That is true. Red blood, so write down all these things. I don't want you to just put T and F. Don't just put T and F. It's useless. You must write why it is true, why it is false. I tell that, but I tell it very fast. And you must quickly jot down the important things that I am telling around that question. Because a lot of theories is being told. Red blood cell counts indicate renal tubular acidosis. Wrong, false. Why red blood cell counts and also dysmorphic red cells, they indicate acute glomerular injury. So write that down. Famous MCQ. Red cell counts, dysmorphic red cells, and also albumin. Presence of albuminuria. They all indicate glomerular injury, or what you call glomerular nephritis, nephritic syndrome. Right. So that is false. IV furosemide may improve survival. False. Just giving IV furosemide, it only causes some diuresis, and that will help you to remove the pulmonary edema and excess intravascular compartment. But it does not help survival in patients with acute kidney injury. So there's no survival benefit in furosemide. It only gives some symptom improvement, some improvement of symptoms, and that will help you to get rid of excess fluid. Like if you have got pulmonary edema or if you have got peripheral edema, that will help you to get rid of that excess fluid, furosemide, but it doesn't cause any survival benefit. So that is false. Severe acidosis is an indication for dialysis. Yes. So what are the indications for hemodialysis in a patient with acute kidney injury? Write down. The indications for hemodialysis in patients with acute kidney injury. Number one, resistant hyperkalemia. So hyperkalemia, as I told you before, we treat with calcium gluconate, insulin dextrose, salbutamol nebulization, so on and so forth. But if all these patients fail, then the last option is going for hemodialysis. Number two, so resistant hyperkalemia. Number two, resistant acidosis. So when a patient with acidosis, we do give them IV sodium bicarbonate. But even after giving several cycles of sodium bicarbonate, if the patient is still acidotic, then you have to go for dialysis. Number three, if the creatinine levels are persistently rising, then that's also an indication for dialysis. Number four, if the patient has got severe fluid overload, particularly causing severe pulmonary edema, resistant pulmonary edema. So pulmonary edema we treat with IV furosemide, even we give furosemide infusion. But even after giving furosemide infusions, if the patient is not responding to that and the pulmonary edema is getting worse, then you have to go for dialysis. Those are the indications for dialysis. See, now those sometimes you don't see in textbooks also. So I give lots of theory made in one question, just like teaching a separate topic. Question number two, regarding myasthenia gravis. So myasthenia gravis is an autoimmune condition where you develop antibodies against the acetylcholine receptors. Antibodies against acetylcholine receptors in the muscles, either ocular muscles, skeletal muscles, or even subrespiratory muscles. So you have anti-acetylcholine receptor antibodies. And when you get myasthenia gravis, you classically get this muscle weakness, and that we call as muscle fatigability. So when they wake up in the morning, they are quite all right. But as the day progresses, the muscles get fatigued. So pupillary reflex is affected. No. When you get ocular myasthenia, you get weakness of ocular muscles. You get ptosis. Write down these things. Ocular myasthenia causes bilateral ptosis. What is that? Drooping of upper eyelids. We call it ptosis. So you can get ptosis, and also you can get extraocular muscle paralysis causing ophthalmoplegia. The patient will complain of double vision, and also patient will be having a squint. But the pupils are unaffected. So the size of pupil is normal and they react to light. So that is false. Touch sensation of hand is affected. False. In myasthenia gravis, it's purely a neuromuscular junction problem. Neuromuscular junction only you get the acetylcholine receptor, and the sensory system is unaffected. So false. Thymic hyperplasia is associated. Yes, so there are two conditions which cause myasthenia. One is your autoimmune autoantibodies, and the other one is the thymus gland. You can get a thymoma, and also you can get thymic hyperplasia. That's correct. Muscle biopsy is needed for diagnosis. Wrong. You don't need muscle biopsy. you can just, it's a clinical diagnosis. So muscle biopsy is not always needed. It's a clinical diagnosis, but muscle biopsy can be done, but not necessary for a diagnosis. So that's wrong. When they say needed for diagnosis, that's wrong. Aminoglycosides improve fatigability. False. Aminoglycosides worsen fatigability because aminoglycosides like gentamicin or amikacin, they worsen the fatigability. That is again false. Question number 3. Regarding Guillain-Barré syndrome, presence of a, just give me a second. Okay. So Guillain-Barré syndrome. So what is Guillain-Barré syndrome? That is acute demyelinating polyneuropathy. Guillain-Barré syndrome is acute demyelinating polyneuropathy. So whatever this is again autoimmune condition, after a diarrheal illness or after a respiratory tract infection, you develop antibodies against your myelin sheath. So those antibodies against the myelin sheath, they will cause peripheral nerves to get demyelinated. Due to demyelination, your nerve conduction velocities are reduced. So nerve conduction velocities are reduced, and that's why you get weakness. So the weakness usually starts in bilateral lower limbs, low down, and it usually ascends starting from the feet. It ascends upwards. So that's called ascending paralysis. It's called ascending paralysis. It also travels to the upper limbs. Also, it travels to the respiratory muscles, and that can cause death of these patients. You also get bilateral facial weakness. When you get Guillain-Barré, you can get bilateral facial weakness. Also, it involves the bulbar muscles, and you can get even bulbar paralysis. It's a clinical diagnosis supported by nerve conduction studies, and the treatment of choices, you have to give intravenous immunoglobulins. You have to give intravenous immunoglobulins, right? So supported, it's a clinical diagnosis supported by nerve conduction studies, but you don't wait until nerve conduction studies. You immediately give the drug of choice, which is intravenous immunoglobulin. And on the 14th day of the weakness, you do a nerve conduction, lumbar puncture, and analyze this cerebrospinal fluid, where you can see the protein levels are very high. The CSF proteins are very high, but the cells are normal. Now, when you take bacterial meningitis, they are also, the proteins are high, but the cells are also high. Here, the cells are normal, only the proteins are high. So that's called cytoalbumin or cytoprotein dissociation. Right, let's see the questions. Presence of a sensory level is characteristic feature. False. In Guillain-Barré syndrome, it's only a motor nerve problem. Only the motor nerves are affected, losing the myelin sheath. So sensory fibers are unaffected, and there's nothing wrong with the sensory system. And their bladder bowel involvement is rare. Write that down. Bladder bowel involvement is rare. But you do get autonomic failure. Guillain-Barré syndrome, you can get autonomic failure as well. So A is false. B, exaggerated tendon reflexes. No, when you get Guillain-Barré, your reflexes are absent. You get what is called areflexia. Sensory system is unaffected and you get areflexia. Reflexes are absent. So there is also false. Dysarthria is not a feature. False. Dysarthria is a feature because you can get bulbar paralysis, and bulbar paralysis causes dysarthria, even dysphagia. Cerebrospinal fluid protein is increased. True, I taught you that. That's called cytoprotein dissociation. Steroids improve the prognosis. False. Steroids have no place in management, and the treatment of choice is intravenous immunoglobulins. Question number 4. Following favors the diagnosis of bronchiectasis over COPD. So there are two pulmonary conditions, chronic pulmonary conditions. One is bronchiectasis, where you get permanent dilatation of the respiratory in the bronchioles, where you get chronic infection and inflammation, which causes pus, chronic pus collection, which where patient complains of productive sputum, productive cough, where they produce large amounts of khaki colored or brown colored sputum mixed with blood, hemoptysis. They lose weight, they get finger clubbing, and on auscultation you can hear bilateral post crepitations with bronchial breathing. Those are some features of bronchiectasis. In COPD, you get bilateral reduced diantry with bilateral wheezes. You get hyperresonant percussion note, what we call AR trapping. And in COPD, is very closely associated with cigarette smoking. So hyperresonant percussion note falls that favors COPD, not bronchiectasis. They are asking bronchiectasis over COPD. So a hyperresonant percussion note favors COPD and not bronchiectasis. So this is how you have to get the MCQs. This is why students don't get the high marks in MCQs. That is because they don't read the question and they don't grasp the question properly. If you have grasped, guys, actual MCQs are quite easy, very easy. But students, they don't pay a lot of attention to these questions. Now here, actually the answers should favor bronchiectasis rather than COPD. So hyperresonant percussion note favors COPD and not bronchiectasis. That's false. Finger clubbing, true. Finger clubbing is only seen in bronchiectasis but not in COPD. Hemoptysis, again true. In bronchiectasis and COPD both cause productive cough, but the infected khaki colored sputum with hemoptysis only produced in bronchiectasis. Whereas in COPD, you can just get a whitish sputum. Write all these things. Don't just mark T and F in my classes. I always give a lot of theory, but I'm giving it fast. You need to jot down quite fast. When you do things fast, your memory is better. It's accepted. And when you just study very slowly, sometimes your mind goes, it's not very specific. Mind starts wandering in here, there, and everywhere. But if you do things fast, you're focused. Mind has no time to go everywhere. So hemoptysis is true, and bronchial breathing is also true. If they have mentioned coarse crepitation, that is also true. Honeycomb appearance is just X-ray, that is true. Honeycomb appearance, then the other feature is called signet ring appearance and tramline shadows. Signet ring appearance and tramline shadows, they are mainly seen in HRCT, but also you can see just X-ray. That also favors bronchiectasis rather than COPD. So that is true. Question number 5 regarding Addison's disease. Addison's disease is where you get primary adrenal insufficiency. Primary adrenal insufficiency, where your cortisol hormones are very low. So in Addison's disease, due to lack of cortisol, your sodium levels are low and the potassium levels are high. They go into hypovolemia, their blood pressure is low, volume is low, they get hypoglycemia. Write down these things. Huh? So what are the features? Sodium is low. You can write down, I'll just put. So Addison's disease, these are the features. Low sodium, high potassium. And the blood sugar is low, they go to hypoglycemia. Blood pressure is low, hypovolemia. They also get postural hypotension. They get pigmentation. They get dehydration and abdominal pain. Dehydration, abdominal pain. They also get, low sodium, high potassium, low blood sugar, low blood pressure, postural hypotension, pigmentation, dehydration, and abdominal pain. Those are some of the features of Addison's disease. You diagnose this by low cortisol level, reduced cortisol level, and to confirm that, so this is a screening test, random cortisol, or you can do 24-hour urinary cortisol level, which will be low, and the diagnostic test is called short synapton test. Short synapton test. Short synapton. Means when you inject ACTH to these patients, their cortisol level doesn't rise. So in Addison's disease patients, your cortisol is low, but the ACTH is high. And the treatment of Addison's is you have to give hydrocortisone. What is the treatment? Hydrocortisone. All this I have beautifully explained in the endocrinology lectures. You can go through my endocrinology notes. We have uploaded that to Study Reserve. All these lectures beautifully uploaded there and very comprehensive, very exam oriented. All the questions you can answer from those lectures. So please go through them. So regarding Addison's, hyponatremia is characteristic. Yes, it is characteristic. Then so true. Hypertension false, it is hypotension. Hypoglycemia true, I taught you. Increased skin pigmentation correct, suggestive. Abdominal pain is recognized true. I just taught you that. Typhoid fever. So that is due to infection by Salmonella typhi. Salmonella typhi causes typhoid fever. So what are the classical features of typhoid fever? You get high fever, write down these things, high fever spikes, very high fever spikes. We call it step ladder fever pattern. You get frontal headache, you get dry cough. And you also get a relative bradycardia. That is, during fever, you expect tachycardia, but here you get low heart rate, relative bradycardia. You also can get, those are some of the features during the first week of typhoid fever. During the second week, you get clinical features like soft splenomegaly. Then you get rose spots. You get erythematous rash on the abdomen called rose spots. A doughy abdomen, D-O-U-G-H, doughy abdomen. And also you get initial constipation followed by diarrhea. So during the first week, you can get constipation. Towards the latter part of first week and also during the second week, you get diarrhea. So initial constipation followed by diarrhea, very important. And the third week is the week of complications where you can get intestinal perforations, intestinal hemorrhages. You can go into acute kidney injury, splenic perforations, things like that. Sometimes you also can get endocarditis. So intestinal perforation, intestinal hemorrhages, acute kidney injury, endocarditis, those are known complications. How do you investigate? The investigation of choice is blood culture during the first week. During the second week, you can do the serology. What is the serological test? You can do the Vidal test, or there is a Vidal test, or we call it the SAT, standard agglutination test, where you look for the high ricin titer of O antigen or the antibodies against O antigen. What is the treatment of choice? You will give intravenous ceftriaxone. So very high fever spikes suggest the diagnosis is true. It suggests correct. Presence of rash exclude the diagnosis false, because you do get a rash that's called rose spots. Causes firm splenomegaly false. It's a soft splenomegaly, soft spleen. False. Positive Vidal test suggestive, correct. During the second week, positive Vidal test is suggestive. Treatment via transmitted via contaminated food. Yes, it's a fecal-orally transmitted disease. Fecal-orally transmitted disease. So infected person's feces will contaminate water supply or some food, and the susceptible host will ingest that and he will get the infection. It's true. Last question. Correctly compared nail changes. Dermatology question. Half and half nails in chronic kidney disease. Very true. Half and half nails are when you take the fingernail, the proximal half will be pink and the distal half will be, the other way around. Proximal half of the nail will be whitish and the distal half of the nail will be pinkish. That's called half and half nail sign. Distal half. Distal half of the nail will be pinkish and the proximal half will be whitish. That's called half and half nail, which you get in chronic kidney disease. Leukonychia, white nails. White nails are very recognized feature of hypoalbuminemia, particularly in chronic liver cell disease, cirrhosis. In cirrhotic patients, you get white nails, leukonychia, due to hypoalbuminemia. Koilonychia is where you get spoon-shaped nails. Spoon, just like a spoon. So our nails are convex, but here you get concave nails, spoon-shaped nails, and that is suggestive of iron deficiency anemia. So that is true. Nail pitting, psoriasis, correct? On the surface of the nail, you can get some pits that happens in psoriasis, and also you get another feature in the nail called onycholysis. Onycholysis, ONYCHOLYSIS, onycholysis in psoriasis. Then Mees lines in arsenic poison, very true. Mees lines are double lines that you get across the nail, double lines you get across the nail, and that is suggestive of arsenic poisoning. Right, all five are true. So, I think that's the end of today's class, the free class. So, when we do, as you can see here, when we do single best answer questions and also MCQs, we are not just mentioning true and false. We are in the MCQs, we don't just give true and false. We always give theory behind that, and we tell why this is true, why this is false, and how to do more questions around that. Also, we teach single best answer questions. We just don't do one question. We do a lot of theory around that, and also we do a lot of subject matter around that, and that is relevant. The exam-oriented subject matter, not just some subject matter, exam-oriented subject matter. That's how our classes we focus at. And if you do like that, your exam is very, very easy. You can definitely get a victory in your medicine exam. So, guys, what I'm saying is, rather than study, always concentrate on doing some question-based learning. You read around the question, and because the questions are the areas where they mostly question. Those are the examiners' interested areas. So you have to read around that rather than reading all the unwanted areas, right, during this short period. So if you do like that, so in our classes, we concentrate on these exam-oriented stuff, which will definitely secure you a victory. All right. So all the best. And so from next weekend onwards, from next Sunday onwards, we are going to start the 2 single best answer classes targeting the upcoming exam. So every day, every Sunday, we are covering that 3-hour class. We are covering 2 topics, like starting from cardiovascular system. So like cardiovascular system and respiratory system, like that, 2 topics will be covered in one class. So we'll do a lot of important single best answer questions in that area, in the subject matter. And based on the single best answer questions, I also teach you subject matter. But I go through a little faster, because the thing is, you can't just pamper and you can't drag and do it very slowly. Then you won't be able to finish the syllabus. So this is the best way of learning. So we are going to start our single best answer classes plus MCQ program starting from next Sunday, targeting the upcoming ERPM exam. So hope you have enjoyed these free lectures, and that will also help you to understand how effective our classes are, and also then you can join our classes starting from next Sunday, and you also can tell your friends the value of these classes, and you also can ask your seniors the value of our classes. So I hope you guys will join from next Sunday. So let's get into the pathway of definitely making a victory in the medicine exam, the upcoming exam. Okay, so thank you very much for participating. All the best and have a good night.